Welcome everybody. We'll make a start if that's okay, because we had it in the diaries for 1 o'clock. So today we've got our lunch and learn session, which is just to go over some reminders about PQS, and we also use it as an opportunity to do a bit of CPD as well. And this session today is going to look at the dietary management of chronic constipation in adults. So for those that don't know me, I'm Sarah. I'm the lead prescribing dietitian for Bob ICB, and I'll just let my colleague Naomi introduce herself as well.
Hello there, I'm Naomi, one of the other dietitian prescribing advisors.
So our plan for today is just to go over our usual PQS reminders, and also to give an opportunity for anybody to ask some questions as well. We'll also give a reminder about our position statement that we've got in Bob relating to ONS and their use in care homes. We've got our education element concentrating on constipation management, and then there's an opportunity to ask any questions at the end as well. So with regards to the PQS dietetic target, that relates to our aim is to reduce our prescribing of our 6 non-preferred ONS products, and I've got them listed on a slide in a minute. So our aim is to reduce the use of these products compared to our total ONS items, and then your practice will be awarded points based on your performance. Our ideal is to have that percentage to be at 30% or lower. So if you achieve that for the non-preferred products, you will be given 15 points. If your prescribing sits between 30 to 35%, you would receive 10 PQS points. And if your prescribing is less than 40%, but more than 35, you would achieve 5 PQS points. We also had 5 points being awarded for an introduction of a standard operating procedure as well, and the deadline was for submitting that was August last year. If you haven't put a SAP together, we still encourage you to do that, as essentially it introduces a process within your practice around supporting patients that are being discharged from ONS from secondary care. So it gives your practice a process for how you would manage those prescription requests, and also for any other prescription requests relating to oral nutritional supplements as well, to ensure that those requests are aligned with our formulary, and obviously supports your overall achievement with your PQS target as well. We also always take the opportunity to remind practices that we have some templates on SharePoint. So if you haven't come to one of these before, we have some templates on SharePoint relating to AccuRx messages, and also email templates for dietitians as well. So if you get a prescription request from a dietitian and you're not sure why they're requesting a non-preferred or a non-formulary oral nutritional supplement, there's a template for you to use to ask for that clarity. And also there's some text messages templates as well that you can use to collect up-to-date weight information from your patients as well, and also to set expectations around oral nutritional supplement prescribing as well. So they're sitting on SharePoint, and the link is there in the slide deck. If you're wondering how your practice is getting on with your PQS performance, we also have a dashboard that's available on SharePoint as well. And just to remind that the data that we use for this dashboard takes out any prescriptions that have been dispensed by Abbott or Nutricia Homeward Service. So we try and remove those patients from the data that are potentially using an oral nutritional supplement, but administering it down a feeding tube. So you can check that there. And just generally to give you a feel about how we're getting on overall as an ICB, our baseline data at the commencement of the PQS scheme was looking at the prescribing data between April 24 and December 24 on EPACT, and that showed us that 42% of our total adult ONS prescription items were for our 6 non-preferred oral nutritional supplement products, and they're listed there on the slide. From our latest EPAC data, so that's for the 9-month period rolling between February 25 and October 25, this shows that this percentage is reduced to 29%. So we're definitely seeing a decrease in the non-preferred oral nutritional supplements being prescribed. So thank you for those practices that are supporting that achievement and are working towards your PQS. And just a reminder about ONS and the use via feeding tubes. We just wanted to remind practices that we do have an enteral, an adult and paediatric tube feed formulary. So if you do get any prescription requests for tube feed or enteral feeds, please look at this formulary. And it's worth noting that 40-sip bottle, 40-sip compact and the 40-sip compact protein, they are listed on the tube feed formulary, but these ONS are also in our PQS scheme. So this slide probably summarises that better. So we've got the 6 non-preferred ONS that are part of this year's PQS scheme listed on the slide, and it reminds you what their formulary status is on the tube feed formulary and on our oral nutritional supplement formulary as well. So it's a good reminder of how they sit. And we also wanted to take the opportunity to reassure as well. We are aware that there may be clinical situations where one of those non-preferred ONS may be clinically indicated for a patient, and the healthcare professional making that request should provide this clinical justification to you so you can understand the rationale. If you have several patients at your practice that are still being prescribed these non-preferred supplements, we're not going to penalise you for having to do that at the end of the financial year. It's just we need reassurance that every opportunity has been taken for them to be on a formulary compliant option. At the end of the financial year, once all the EPAT data has been reviewed for this target, we will contact practices to let you know what your PQS achievement is. Any practice that has exceptional reasons for having not performed as anticipated despite working to achieve this target can submit an appeal, and the appeals process will be communicated by email at the end of the PQS scheme. If your practice has several patients prescribed those non-preferred ONS with a valid clinical justification, please keep a record of the reasons for this, and we have put together a suggested spreadsheet because we have had a few practices contact us to say we're doing our best to do our PQS, but we've got these exceptional reasons why a patient can't go on to an alternative formulary or a nutritional supplement. So we've got a suggested spreadsheet there, or you can use your own templates. If you're concerned you may not achieve target, then we would suggest that you start documenting the reasons for that now, so it makes it easier if you do want to put an appeal in at the end of the PQS period. We also wanted to remind you about the ICB position statement that came out in September last year. So this just states that the ICB does not support the routine use of adult oral nutritional supplements for care home residents unless there is exceptional criteria being met. We have reminded our dietitians and care homes across the BOB footprint of this position statement, and we are currently undertaking training with care homes as well to remind them of this and also upskill them on how to use food-based strategies to address a care home resident's malnutrition risk. So for a care home resident who's been identified as being at high risk of malnutrition, we would anticipate that most residents can be managed using food-based strategies. The reasons where we'd expect ONS to potentially need to be prescribed would be if that resident is being tube fed and they're administrating that ONS down their feeding tube, or the resident has dysphagia and they require thickener to thicken their fluids, and they have a MUS score of 2 or more. We know that thickening homemade supplements is incredibly difficult, so in those situations they may require a dysphagia specific oral nutritional supplement. Or in exceptional circumstances where a GP or a specialist practitioner, such as a dietitian, consultant or care home support service nurse, has suggested that food-based strategies aren't working for that particular resident, and then they may need a short-term use of an oral nutritional supplement instead. So they need to provide the clinical justification of what those exceptional circumstances are. Care home staff should be following the malnutrition pathway that we have in place, and that reminds care homes for each resident they should have a nutrition and hydration care plan in place that should be devised to address their malnutrition universal screening tool or their MUS score risk, and that should be specific to that particular individual, taking into account their dietary needs and their likes and dislikes. And it reminds care home staff that they can escalate or make a referral to a dietetic or care home support service as needed, depending on that person's individual circumstances. This slide just reminds you of the training sessions that we have available. So if you do work with any care homes within your practice, please encourage them to come to the training. We have some in-person sessions, or we do have some virtual training sessions as well. Next, we'll move on to then the information that we were going to do around our update around chronic management of constipation in adult patients. Before I just move on to that bit, are there any questions relating to PQS at all? No? Okay. So we have some new guidelines that came out from the British Dietetic Association, and they're guidelines for the dietary management of chronic constipation in adults. They were reviewed by dietitians and experts at King's College London and are now available to read in the Journal of Human Nutrition and Dietetics. I've put the link on there. You can get the full text version of that article for free. The guidelines are relevant to adults with chronic idiopathic constipation, and the new guidelines focus on key foods, drinks, and supplements. And they've been developed using a comprehensive systematic review of the evidence. There have been 59 recommendations included on ways to support patients to improve their chronic constipation symptoms. And these are the first guidelines specifically for the dietary management of chronic constipation. And they are based on evidence from the robust systematic reviews, and they followed the grading of recommendations, assessment, development, and evaluation. So the approach when they're reviewing that evidence base. The advice may be helpful for your patients in your practice who are living with chronic constipation, and it may be worth revisiting the dietary strategies they are currently using to support that symptom management, or if you get a patient complaining of a new presentation of constipation, then we would suggest you consider how potentially they could use a diet approach to manage that symptom. So the background to the guidelines were that there's current clinical guidelines for chronic constipation, but they offer limited dietary recommendations. And the aim of the research was to develop the first comprehensive evidence-based dietary guidelines for the management of chronic constipation in adults. The researchers looked at the evidence from many high-quality studies by carrying out 4 systematic reviews and meta-analysis of eligible randomized control trials. They combined the results to see which treatments showed consistent benefits, and then an expert panel will then assess the strength of the evidence using that grade system I just referred to. And then they agreed the final recommendations through a structured consensus process. Only findings that have been supported by at least 2 randomized control trials were included in the guideline. And just to give a reminder really about recommended daily fibre intakes. So for UK adults, we should all be consuming around 30 grams of dietary fibre daily for optimum health benefits. So that includes supporting your health, digestive health as well. And we know for chronic conditions, there's lots of evidence to show increased fibre intakes can prevent long-term chronic conditions such as diabetes and heart disease as well. What we do know from evidence that most people are not eating enough, or most adults aren't eating enough fibre. So average intakes is around the 18 to 20 grams per day. So we are definitely below that recommended, typically below that recommended level. This slide is just trying to show what a high fibre daily daily intake would look like. So if you're aiming to achieve that 30 grams of fibre per day, this is what it would look like in terms of a food approach. So in terms of breakfast, if you were making porridge, we would be aiming to have a portion size of around 40 grams of dried oats mixed with milk. If you top it with your banana and some chia seeds or flax seeds, that would give you around 8 grams of fibre, sorry. And then lunch, if you had a thick homemade lentil or bean soup with a slice of wholemeal bread, that would give you another 8 grams. A snack could look like a handful of almonds, approximately 30 grams, and then adding an apple with that still has its skin on would give you another 4 grams of fibre, sorry. And then dinner, it would look like wholemeal pasta. The serving size would be about 75 grams of dry pasta, and then adding to that tomato sauce mixed with vegetables such as peppers, mushrooms or spinach, and then topped with your chickpeas would give you another 10 grams. So that's what 30 grams would look like. So you can see it's achievable. I don't know if you talk to your patients very much about what their daily diet looks like, but with planning you can definitely get it in, but you need to concentrate and obviously make those choices, looking for those wholemeal options and thinking about how you can get that in throughout your day. Obviously legumes such as chickpeas, black beans, all those kind of things are a really good source of fibre, but I don't know how often we're always seeing that in our patients' diets or our own diets as well, but they're definitely a valuable source of fibre. So in terms of what is chronic constipation, it's characterised by unsatisfactory defecation that results from both infrequent stools, difficult stool passage, or could be both. It affects about 10% of our global population, and it significantly impacts quality of life and can result in considerable financial burden to both patients and healthcare systems. Nearly all patients do try some form of lifestyle management for symptom relief, including dietary modifications. But the researchers found that primarily they focus on increasing fibre intake. However, more than half of patients that try that type of approach are not satisfied with their current treatment, highlighting a need to improve our management strategies for chronic constipation. And in terms of just giving some kind of context around, I guess, prescribing, the MOT team has got a campaign related to prescribing of over-the-counter products. And I admit this isn't for chronic constipation, but it is for infrequent constipation management. You can see that we're spending in financial year 23-24, we spent nearly £1 million, and last financial year we spent over 1.1 million on over-the-counter products to treat infrequent constipation. And in terms of diagnostic criteria for functional constipation, we would be looking at the Rome criteria. And for somebody to be diagnosed, they would need to fulfill the have had symptoms for the last 3 months and have 2 or more of the below that's listed there on the slide, and have an onset of at least 6 months prior to diagnosis. So in terms of symptoms, it would be 2 or more of any of the following. So straining during more than a quarter of defecations, lumpy or hard stools, again for more than a quarter, sensation of incomplete evacuation, sensation of anorectal obstruction or blockage, manual manoeuvres to facilitate more than a quarter of defecations, and fewer than 3 spontaneous bowel movements per week. Loose stools are rarely present, but only without the use of laxatives. And then we've got insufficient criteria for IBS. So they would be how constipation would be diagnosed. And recommended, there's several dietary modifications for symptom relief. However, there are considerable limitations with these guidelines, which may help explain why patients report such a treatment dissatisfaction. They focus only on limited selection of dietary recommendations, and primarily advice focuses on increasing fibre intake and adequate fluid intake, omitting any other dietary strategies for which there is an evidence base. Some guidelines include dietary recommendations for which robust evidence does not exist or does not support their use in constipation. And the current guidelines are sometimes vague, so it might just say increase fibre intake, but it lacks detail, for example, on the specific evidence base for which types of food that would help achieve the recommendations and the optimal mode of administration as well. So I'll hand over now to Naomi, who's going to take us further through what the current guidelines are saying.
So when a patient is presented to you, before getting into the dietary recommendation, it is always worth just a common sense approach to just check if they're on any medications that might be causing these constipation. I've listed a few that are known to have that side effect due to the action of what they're trying to do. You can also have the side effect of constipation because they're acting on the gut wall by slowing down the peristalsis movement. So they're slowing down the passage of stool, but also causing water reabsorption, which then can make the stools harder and then harder to pass. But we always want to take a holistic approach to managing constipation because it can be diet related as well. It can be to do with their leisure activities and relaxation or lack thereof, and lack of physical activity can slow down bowel movements as well. In terms of the overall recommendations from these new guidelines from the British Dietetic Association, I've got a summary slide, but we'll go through them step by step. This is more for your looking at the slides afterwards and wanting a quick reference tool. So if we go through them all, firstly, we're going to look at the fibre-based interventions and what strategies they've given and what the evidence is saying. Put it together into a table. So as Sarah said, there were 59 recommendations. We've tried to pull out what is usable for clinicians and how strong the evidence was. They did grade it in terms of whether their recommendations were, the evidence was strong or low or moderate. So in terms of fibre, they've given some examples of the types of fibre supplementation, but there is definitely benefit to supplementing fibre. That is, as we know, a cornerstone of managing constipation. And they've looked at different specific types. So psyllium had the best evidence, most evidence supported option. It's strong evidence, high effectiveness, and the clinical trials indicated that when doses were exceeding 10 grams a day for at least 4 weeks, that's when it had significant improvement for stool frequency. So the participants were seeing an increase of extra 3 bowel movements per week. They also saw softened stool consistency and reduced straining severity. That's very positive. It does perform even comparably to osmotic and stimulant laxatives, so it should be made like a first line recommendation, something we should start with getting the patients to try. It is recommended they start with less and then gradually increase. So the evidence, the studies are showing just 3 grams a day did benefit, but if they could get even above 10 grams, that's where the benefits were even greater. But it is important to titrate up gradually and also accompany that with sufficient fluid to minimize any GI discomfort. Another fibre supplement was pectin. That did also show some promise. That's a slightly different type of soluble fibre. I'll explain a bit more in the next slide, but the evidence showed pectin was shown to improve stool consistency and then reduce the time spent on the toilet. We know that with people with constipation, they can spend a lot of time trying to get a complete evacuation and can spend quite a bit of time for that movement to occur. The evidence was more limited though with the pectin compared to the psyllium. Other fibre sources such as oat bran or flaxseed flour and other high fibre cereals, they may help, but the data was insufficient for any of the more formal recommendations in the guidelines. And inulin type fructans were shown to improve stool consistency, but not how often they were going and opening their bowels. And the key there, the inulin type fructans were shown to worsen flatulence. So for a lot of the studies, they were looking at stool frequency, consistency, overall symptoms, and then also some of the individual symptoms shown in constipation, like frequency of straining or severity of straining. All the different ones were covered. Some other fibre supplements that they were seen in these studies were mixtures of fibre, polydextrose, and galacto-oligosaccharides. They generally failed to improve constipation symptoms and often exacerbated bloating or gas. So overall, clinicians should emphasise the psyllium and consider pectin as well as a secondary option, and consider avoiding fibre blends just because the evidence was more poor for those and they had more adverse effects like the bloating and the gas. In terms of a little bit of explanation about what this means, psyllium husk is one of the soluble fibre supplements and it's derived from that Plantago ovata seeds. And just as a note, the aspergilla husk, or you might know as fibre gel or ispergel, is also derived from the Plantago ovata seeds. I would not be able to explain if it's a different part of that seed that's used in those different supplements. I'm not sure, but these seeds and their husk do contain really high levels of fibre, and they work by absorbing fluid, and then it becomes gelatinous, and that helps soften stools, make them easier to pass. And pectin works in a similar way. It's found in fruit cell walls, also absorbs water, and that's how they work in our guts. And that was just a summary of what to avoid. Prunes, actually, funnily enough, did not have a lot of evidence for them. I know they're very well known, very well recommended, commonly shared. Have prunes when you're constipated. In these guidelines, they weren't shown to have a significant benefit compared to psyllium in controlled trials. So that's where the studies were showing psyllium versus prunes. Then the wheat bran and mixed fibre supplements didn't show any consistent improvements in the stool frequency or global symptoms, and we do know they increased flatulence as well. And a lot of things I've already mentioned about those polydextrose and galacto-oligosaccharides exacerbating bloating. So yeah, just not going to repeat myself there. All in all, I could stick to the psyllium first, and there are some other supplements as well we're about to go into that also are showing some potential benefits as well. Next on to probiotic interventions, something else we commonly see recommended for constipation. So the probiotics have been extensively studied for constipation, but we are still seeing mixed results. And generally the recommendation stands that you should try a supplement for 4 weeks. If it works, carry on. If it doesn't, try something else. And by, following the manufacturer's guidance for how you take it, whether it's a sachet a day or 2 tablets a day or something. There were some specific strains highlighted within the guidelines that showed some more specific benefits, and that was the Bifidobacterium lactis that showed small to moderate improvements in stool frequency, and that was shown across multiple studies, but it didn't have consistent results for the stool consistency or those global symptoms. Another key bacteria was the Bacillus coagulans, particularly a strain called unique IS2 that was shown to reduce abdominal pain associated with bowel movements. So that could provide some extra relief for patients. There wasn't enough evidence with these multi-strain probiotics, generally inconsistent, and that's likely because of the difference in the studies. That in one study, the multi-strain probiotics have X, Y, and Z strains of probiotic, but then in the other studies, it was A, B, and C types of probiotics. So it's very difficult to analyze those together. And so if they had a benefit overall. It is important, though, that as a clinician that you're setting realistic expectations when recommending a patient tries probiotics, that the evidence is a little bit inconsistent, but there is definitely a potential benefit. It's more about finding what works for them, as opposed to us being able to say specifically, try this, it's going to work. So yeah, there were some individual randomized control trials that did show benefits with these certain species, the Bifidobacterium lactis and the Bacillus coagulans for those the stool frequency and the abdominal pain. But overall, no single probiotic strain has consistent evidence for those overall constipation outcomes being improved. And most probiotic strains, unfortunately, are failing to demonstrate this meaningful clinical benefit for constipation. Then there was lots of other probiotic strains studied, various different ones. I won't name them all because they've all got very long names, but unfortunately they lacked the sufficient evidence to make a recommendation. So, or there weren't enough trials of the same one twice. Sarah was saying that there had to be 2 studies at least of that supplement against against a control. So all in all, I think the guidance is still standing that advising the patients to try the probiotics for 4 weeks, and if a benefit, continue. If not, try an alternative, but we're not yet got enough evidence to recommend specifics, although they may be open to trying these Bifidobacterium lactises ones more specifically.
2025 to 2026,
for
34K.
Bear with me. For stool frequency, and if pain is a bit more of a problem, you may want to consider suggesting the Bacillus coagulans types, but overall it's not very consistent evidence. Now, in terms of symbiotics, so just to explain, that is where a product contains both the probiotic, which is the beneficial bacteria, plus the prebiotic, which is the food that bacteria then eats to enhance how beneficial that bacteria are. Overall, the symbiotics weren't shown to significantly improve the stool frequency, nor the stool consistency, nor global symptoms. And that is just because our evidence is limited. There were very few randomized control trials looking at symbiotics, and again, those differences. So the different studies would look at different symbiotics. Some of those symbiotics had that type of probiotic versus other studies having a different probiotic, and the prebiotic types are different. So it just makes them really hard to compare. We do need more studies on that to show how effective they may be. Looking now at other dietary supplement interventions. Firstly, magnesium oxide. So this one had one of the strongest evidences throughout the guidelines. So at doses of 0.5 to 1.5 grams per day for at least 4 weeks, that was shown to really significantly improve stool frequency. So more than 3 bowel movements extra a week, plus softened their stool consistency, plus reduced how severe their overall symptoms were, and straining, and bloating, and incomplete evacuation, and quality of life. So there was a lot of really positive, significant evidence for magnesium oxide. However, in the UK, you can get magnesium oxide and purchase it on the high street, but in terms of the doses, a little bit hard, and you can't find it as a pure single ingredient. And as a safety note, it might not be suitable for those patients with a renal impairment or those on electrolyte restrictions. As a safety, now we wanted to pull out, there's so many different types of magnesium supplements. So we just wanted to explain what we know about it, because they weren't all studied in these guidelines, and unfortunately. So the magnesium oxide is the one where they had produced these recommendations, versus magnesium citrate is often used for constipation in practice, and we use magnesium glycinate sometimes for bowel prep and other things. So magnesium oxide, if you were to pick that up off a shelf, it would say things like for bone care or for muscle care or for energy. It doesn't say for constipation on there. We know, so I'm just looking on my other screen, it's a bit bigger. So magnesium oxide, it's a little bit less well absorbed than magnesium citrate, and they both work by drawing more water into the bowel, the oxide and the citrate. And magnesium oxide is easier to purchase. So if you went into Boots and saw magnesium and turned over the packet and looked at the label, it would be magnesium oxide in the tablets. But we don't have as much information about them in terms of our NICE guidelines. For constipation, it doesn't say magnesium oxide. So if you were to prescribe something that it doesn't, though it is prescribable as well, so it's very hard to explain. And Sarah, come to my rescue at any point. But magnesium oxide, you can purchase it. It is prescribable on the DMD, but is not licensed for treating constipation. Sarah, thank you for helping me.
Yeah, no, that's correct. I think in terms of the magnesium oxide advice, that's a new piece of evidence, I guess, in managing chronic constipation. So patients are welcome to purchase that and try for themselves. In terms of a prescribing point of view, I know this guideline's been in dietetic communities been talked about a lot, and I guess dietitians just working in general posts who perhaps not got a prescribing awareness are asking whether patients can be prescribed this on the NHS, and at the moment magnesium oxide is prescribable as a supplement, but not specifically for treating constipation. So it would be useful to know if anyone's had that in their practices. Have people been coming in asking for prescriptions for these particular products, or there may be something that you might get asked in the future, because there's definitely been quite a lot of emphasis on that. This has been the first bit of evidence that we have really to support its use in constipation. So we just wanted to kind of acknowledge that. So it is purchasable. You can buy it, but more online rather than walking into, say, a health food shop or to Boots or any other pharmacies. And that for now, it's not something that's prescribable on the NHS for constipation management, but that could change, I guess, in the future as that evidence base grows.
Thank you, Sarah. The other thing to point out is that, say, Holland & Barrett or Boots, if you were to pick up a bottle of magnesium tablets, the dose is 375 milligrams, but the study looked at least 0.5 grams. So you would have, and that 375 milligrams on the bottles is for 2 tablets a day. So you'd have to think about how realistic is it for your patient to not only take at least 3 tablets a day, but if they were going up to that, titrating up to 1.5 grams a day, that's quite a lot. So in these guidelines, it's the global research pool, but in terms of UK availability, we don't know what they used, but what's available to our market isn't as high a dose. So that's something to be considered in terms of the practicality of the application. Another dietary method was kiwi fruits. You might already be aware of it for constipation, but if not, so in the studies it was shown if you were to consume 2 to 3 of the whole fruit per day, trying that for 4 weeks or more, that was shown to have benefits comparable to psyllium. and that was supporting stool frequency, modest, not quite as strong, I would say, and reductions in bloating and abdominal discomfort. You can obtain kiwi fruit supplements. They were also studied separately, and they were shown to reduce incomplete evacuation and abdominal pain, but didn't have as much of an impact statistically on the stool frequency and stool consistency. So if you have patients that are looking for natural alternatives, or they're not wanting to take tablets, or they're maybe intolerant to fibre supplements, then that's something from a diet method that they can just up their kiwi fruit intake, and it could still help with their constipation symptoms. Another food that was studied was rye bread. In the studies, the dose was 6 to 8 slices a day. So again, something to consider with that practical application, that's a lot of slices of bread to eat, but also if they were then to eat that many slices, would that displace other things that they're eating in their diet? Because to eat that much of one thing, they would have to eat less of something else. And would that then impact their overall intakes? But just to look at what the guidelines were saying, if you were to eat, if the participants that ate 6 to 8 slices of rye bread per day for at least 3 weeks, it showed a modest improvement in their stool frequency compared to white bread. There was a factor that it may worsen their global symptoms just slightly. They had a standardized scale, so it just slightly worsened their overall symptoms, but did improve how frequently they were able to open their bowels. And lastly, we have high mineral content water, different from tap water, so it's the mineral water, but high mineral content water. So the study showed if drinking 0.5 to 1.5 litres a day, daily, for 2 to 6 weeks, demonstrated a 47% overall clinical benefit versus low mineral water, particularly when combined with having extra fibre. So if they were having 25 grams a day at least of fibre, that had the better benefit. However, mineral water alone, it wasn't shown to significantly improve the stool frequency or global symptoms or abdominal pain or quality of life. So these findings do suggest that it's that rye bread and mineral water could serve as strategies, but they shouldn't replace the overall primary interventions that you might want to try, like the psyllium or the magnesium oxide, and we'd have to look at what they can tolerate in terms of having that amount of food and that drink. And key is in these studies it's talking about high mineral content water, and Sarah's kindly put in the table there for what is used in research studies for high mineral content water, but what's actually available to us on the market doesn't have really anywhere near those higher levels as used in the studies. The best is Evian water in terms of that mineral availability, and the key researcher highlighted that it was the magnesium that they believe to confer the benefit in the mineral water. So again, it's useful research, but in terms of that practical application, we might be just a little bit more limited in the UK with what we can do. But you should still be encouraging your patients to definitely drink more. And if they're then going to drink mineral water, then there's going to be that added benefit compared to just tap water. In terms of Senna, so again, one of the key recommendations for constipation we're all very familiar with. However, in this research, they could only find 2 good quality randomized controlled trials that they were able to compare. On their own, those studies showed that Senna had a benefit on constipation. But when they then merged those 2 studies and did analyze them together, that statistical significant improvement was lost. So they weren't able to make a recommendation that Senna should be used to benefit constipation. That can happen with perhaps studies that differ a lot from each other. That could be in their design, it could be in the dose, it could be in who took part, and that can make, when the results combined, it makes the results less reliable. And most of our other research on Senna does come from studies that don't include a comparison group. So the key in these guidelines was that they wanted to use that highest level of evidence. We've got the control of the thing you're testing versus a control. So there's lots of other studies that don't have that control or comparison group. So you just, from that, you can't be sure that the people improve because of the Senna or for other reasons. So we do still need some more quality placebo-controlled randomized control trials on Senna to really establish the effectiveness of it. But at the moment, they weren't able to make guidelines specifically on recommending Senna for chronic constipation. So in summary, what can we actually take away from this research? All in all, clinicians managing constipation should prioritise the interventions that have the strongest evidence, whilst limiting those with more insufficient or negative findings. As the study did start out by saying that nearly half of people are unsatisfied with the strategies they've been trying. So we want to promote and prioritise the ones that have the strongest evidence. And that is the psyllium fibre, so at least 3 grams, if not over 10 grams a day for 4 weeks. The magnesium oxide at 0.5 to 1.5 grams a day, 2 to 3 kiwi fruits per day, rye bread 6 to 8 slices per day, and the high mineral content water of at least half a litre, if not a litre and a half a day, combining that with sufficient fibre intakes of at least 25 grams. And then in terms of probiotics, difficult to be really specific, but the Bifidobacterium lactis and the Bacillus coagulans had the most specific effects on that frequency and the pain, but mostly the probiotics and symbiotics are a little bit inconsistent. There wasn't recommendations enough to recommend the Senna or the prunes or the mixed fibre blends, and we still need more research on these other strategies like fermented foods and caffeine and certain vitamins to see a bit more what else we can recommend. And overall, if you were to focus on the evidence-based approaches, hopefully it encourages your patients, reassures them, and then hopefully could improve their outcomes and reduce their overall symptom burden and minimise trying lots of different things. This obviously is too tiny to read out, but is the most clear way of displaying the recommendations, I would say, from the overall guidelines. So it puts all the recommendations into one table and lists them all down the left-hand side, and then across the top we've got all the different types of symptoms. So I guess if you had a patient in front of you and they're suffering a really specific symptom of their constipation, that table I would say is useful for picking out, okay, which of these recommendations is most useful to that symptom. Or if they were really suffering from wind, then you wouldn't want to choose something that makes the wind worse, for example. So all in all, we would say that the golden principles are to check your patient's comorbidities, any medications that they're taking that might be making constipation worse, and check they're not contraindicated from implementing any of these dietary guidelines, like their renal function and those restricting their sodium intake. It's try and adapt the advice to their lifestyle, their culture, their budget and their preferences, and try and make any changes gradually to avoid intolerance. So we'd always say try one thing at a time rather than all at once, because you want to know what it is that's having the benefit and do the most minimal interventions, and then monitor their outcomes and adjust. So we will take any questions. We appreciate there's a lot there. It's new evidence and the practical application is key. And our next webinar will also be on a Tuesday. It'll be on the 24th of February, again at lunchtime at 1 p.m. And we'll be talking about dysphagia and food first.
Thanks, Naomi.
Okay.
I can't see any questions in the chat, but if there's anything that you want to ask after this, then just drop Naomi or I an email, or you can email the Medicines Optimization team general email address as well, and we can pick up any queries there. But for now, if there's no questions, we will close today's session and then we will put the recording up on our SharePoint page. Thank you everybody for coming.